Type 1 diabetes, T1D, is an autoimmune disease where the body's immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas. This results in a lack of insulin, the hormone needed to regulate blood sugar levels. Without enough insulin, blood glucose levels rise, leading to hyperglycemia. If left untreated, severe hyperglycemia can lead to diabetic ketoacidosis, resulting in coma and death. T1D usually starts in childhood, adolescence, but can manifest at any age. It accounts for around 5 to 10% of diabetes cases. Management requires lifelong insulin injections, pump, along with blood glucose monitoring. However, even optimal current treatments cannot fully replicate the precise insulin regulation by a healthy pancreas. Thus, research strives to find ways to cure T1D via regeneration of insulin-secreting beta cells. This overview will discuss T1D pathogenesis and management, then examine emerging regenerative and cell-based therapies that may offer future hope for a cure. Pathogenesis. The exact pathogenesis of T1D is not fully understood, but involves interplay of genetic and environmental factors, culminating in pancreatic beta cell destruction mediated by the body's own immune system. A combination of inherited susceptibility genes and early environmental exposures, like certain viruses, toxins, or foods, are believed to jointly trigger activation of both innate and adaptive autoimmune responses targeting pancreatic islet cells. As significant beta cell mass declines, insulin production drops, eventually leading to overt hyperglycemia and diagnosis. Genetic predisposition coupled with a probable environmental exposure ultimately converges to break immune tolerance, unleashing destructive autoimmunity targeted specifically at insulin-producing cells concentrated in pancreatic islets. Elimination of beta cells is primarily mediated by autoreactive CD8 T cells and macrophage cytokines. Resulting ischemic damage and metabolic strain on surviving beta cells accelerates their demise. Together, these immunological assaults lead to beta cell mass decrement below the threshold needed to maintain normal glycemia. Current management and challenges. Currently, there is no cure for T1D, and management centers on exogenous insulin administration and diligent blood glucose monitoring to minimize extremes in sugar levels. Fingerstick blood samples or continuous glucose monitors, CGM, provide real-time interstitial glucose readings. Based on carbohydrate intake and activity, subcutaneous rapid or short-acting insulin is given at meals, while long-acting basal insulin is injected 1 to 2 times daily to control between meal and overnight levels. Insulin can be delivered via multiple daily injections or continuously through an insulin pump. Islet and pancreas transplantation are additional options, but limited due to shortage of donor organs. The goal of treatment is maintaining blood glucose levels as close to normal ranges as possible without hyperglycemia, yet this remains challenging. Even the most sophisticated insulins and delivery methods cannot fully replicate the exquisite regulatory precision of a healthy endocrine pancreas. Patients with T1D work vigilantly to balance insulin dosing and carbohydrate amounts, while accommodating varied meal sizes, timing, exercise patterns, stress levels, and physiological changes. However, blood sugars commonly fluctuate out of range. Chronic hyperglycemia raises long-term risks for microvascular complications like diabetic neuropathy, retinopathy, and nephropathy, along with macrovascular diseases. Hyperglycemia causes disruptive symptoms in the short term and can lead to fatal outcomes in extreme instances. Frequent glucose variability also associates with higher cardiovascular disease. The daily self-management burden typically persists for decades. Thus, research strives to discover new therapies offering improved glycemic control, reduced complications, and ultimately, a definitive cure through beta cell restoration. Evolving treatments. Seeking a cure. Exciting research is underway exploring innovative treatments to replace damaged pancreatic beta cells and restore endogenous insulin secretion in T1D. Key strategic approaches include stem cell-derived beta cell regeneration, pancreatic islet transplantation, immune modulation and tolerance induction, and closed-loop insulin delivery systems. Stem cell-derived beta cell regeneration. Stem cells possess abilities to self-renew and develop into specialized progeny cells. Embryonic stem cells, ESC, can differentiate into any cell type, while tissue-specific adult stem cells show limited but renewable differentiation potential. Mesenchymal stem cells, MSC, give rise to mesodermal lineages like fat, bone, cartilage, and muscle. Islet progenitors retaining capabilities to expand and convert into mature functional beta cells have also been identified within adult human pancreata. Key research now focuses on harnessing stem cell plasticity to derive mature, glucose-responsive, insulin-secreting cells similar to natural beta cells. Human ESCs and induced pluripotent stem cells, iPSC, generated by genetically reprogramming adult cells, offer promising platforms for scale-up production of replacement beta cells. Rodent models of diabetes have already achieved euglycemia after transplantation with stem cell-derived beta cell surrogates. This showcases curative proof of concept using regenerative medicine, setting the stage for adapting techniques to generate clinically compatible human beta cells. Teams across the globe, including ViaCyte and Sigilon, now refine protocols steering human stem cell differentiation along sequential stages, emulating pancreatic ontogeny to eventually yield mature, functional beta cells. Encapsulation, with an immuno-isolating porous membrane, may permit transplantation of allogeneic cells, protecting them from immune attack without systemic immunosuppression. Ensuring durable graft survival and function remains a key challenge. Australian researchers recently transplanted custom-engineered, stem cell-derived pancreatic progenitor cells, able to further mature and proliferate in situ, maintaining improved glycemic control months later in diabetic mice. Ongoing incremental advances offer hope that stem cell-based platforms can soon provide a lifelong supply of surrogate beta cells. Pancreatic islet transplantation. Transplanting cadaveric human pancreatic islets containing insulin-producing beta cells can restore glycemic control. However, like pancreas transplantation, its wider use is severely limited by shortage of donor organs. Supply-demand mismatch restricts this therapy to only patients with recurrent, dangerous hypoglycemia, despite optimal insulin treatment. Nonetheless, successful islet transplantation provides proof that replacing beta cells can fully restore euglycemia, insulin independence, and stabilization of glycemic variability without need for exogenous insulin or close glucose monitoring. This underscores the curative potential of beta cell replacement. Recent protocol refinements have markedly improved consistency of insulin independence, now approaching that of pancreas transplantation. Efforts also continue to enhance graft longevity while minimizing reliance on chronic immunosuppression. Translating further advancements to make this a safe, scalable, and effective cure will rely upon solving the insufficient tissue supply bottleneck through either unlimited stem cell-derived sources or xenogenic porcine islets. Immune modulation and tolerance induction. Since T1D arises from autoimmune assault on beta cells, treatments dampening islet-specific autoimmunity could preserve residual beta cells early after diagnosis. However, past clinical trials blocking general immune function showed limited efficacy and significant side effects. Current approaches instead aim to selectively reinstate immune tolerance to beta cells without general immunosuppression. Certain proteins like TNFi that mediate beta cell apoptosis represent prime targets for immune modulation. Antisense oligonucleotides like teplizumab can bind surface T-cell receptors, blocking inflammatory T-cell responses that destroy islets. Other containment therapies focus on resetting the balance between aggressive effector T-cells and regulatory T-cells that normally suppress excessive autoimmune responses and curb collateral tissue damage. Initial human trials found short-course, low-dose IL-2 cytokine preferentially stimulates TREGs, successfully preserving C-peptide in new-onset T1D. Expanded TREGs could also be directly infused as a cellular therapy. These immunomodulation therapies may ultimately integrate with beta cell replacement. First squelching the underlying autoimmunity provides the optimal platform for allografts, or surrogate beta cells, to thrive free from recurrent autoimmune assault. Closed-loop insulin delivery systems. Until definitive biological cures are realized, optimizing external technology like closed-loop insulin delivery offers the most imminent avenue for easing daily burdens of T1D management. Closed-loop systems combine real-time CGM glucose readings with computer algorithm-directed insulin delivery via pump. The artificial pancreas autonomously modulates insulin dosing, responsive to fluctuating blood sugars. Some systems, already approved for home use, suspend insulin when hyperglycemia threatens or mitigate overnight glucose variability. Fully automated versions controlling both basal and mealtime insulin, guided by personalized settings determined with the care team, are nearing FDA approval after successful clinical testing. These closed-loop systems aim to lift the unrelenting hourly demands of decision-making, dosing adjustments, and monitoring intrinsic to conventional T1D self-care. They are the next evolution in care for enhancing safety, easing daily burden, and ultimately improving long-term health outcomes. Recent strategies include stem cell-derived surrogate beta cells, transplantation of cadaveric or xenogenic islets, immune modulation therapies.